I'd like to just start out, just to wake you up a little bit, with a couple of videos with sound of a few patients that are indicative of what we can do to prevent menopause with ovarian freezing and transplantation. Here we go.
Giving new hope to cancer patients like Melissa Durant.
The fact that I couldn't have children really scared and frightened me.
2 years ago, at the age of 21, Melissa was diagnosed with Hodgkin's lymphoma. She was told her treatment would include very high doses of chemotherapy.
I thought, I'm young, I can do it. The odds are looking really great for me. Hodgkin's lymphoma, very curable. And then I really started looking into my papers and my books that you get, and I came across fertility, and I burst into tears.
When she found out the chemo would make her infertile, Melissa turned to Dr. Silber.
Well, Melissa, this is a fantastic moment for all of us.
It is.
I mean, when are you going to have the baby?
We are scheduled for a week from yesterday, so six more days.
6 more days, and you look really ripe.
I am very ripe, yes.
I mean, I just remember, how many years ago was it that you were sitting here at this table and so optimistic about your Hodgkin's? I remember you said Hodgkin's disease, very curable.
Very curable. I have relapsed since, but with advances in medicine again, I'm been in remission for 5 years.
I'm here with Jennifer, who is one of our most exciting, interesting patients. Her name was O'Brien then. She was 23 years old. This was 21 years ago when she was told she had leukemia and was really in severe danger of death. And just before her bone marrow transplant, we took out an ovary and froze it. What do we think?
You were very, very optimistic.
Oh, really?
Yeah, you were. You were.
Okay. Yeah.
And because I remember walking out of our first meeting just so elated, thinking that I was able to preserve my fertility.
I'm always optimistic, and I was hoping we could figure this out. But it was really a long time ago.
It was. Although sometimes it feels like yesterday.
But here she is, 44, and she's pregnant with her 27-year-old ovary. So, if you had not had cancer,
yes,
and you really didn't get married or think about having kids until you were 40 or so, you'd have been infertile anyway. So, let me see. Okay, so there she is with her husband and her baby, 44 years old. Actually, she was 24 when she had the ovary tissue frozen. And it's funny how they recollect incorrectly. I told her I didn't think there was much of a chance at all that freezing her ovarian tissue would ever result in having a baby, because there might be transplantation of leukemic cells if we transplanted the tissue back, and I didn't think that we could culture primordial follicles to maturity, and so it was just all we could do. This was in 1997, and we couldn't freeze eggs at that time, and it was just a desperate thing. And she had to go through 2 bone marrow transplants, and she was on near death, but she survived. And now at 44, with this 24-year-old ovary, she has a baby, and as a matter of fact, her ovary is still functioning now. So it's just an example of the issue we're talking about, the aging ovary, because it's this transplantation of frozen tissue or tissue from identical twins that got me interested in the whole subject of ovarian aging. So this is a talk that Milton's asked me to give in general about the aging ovary. So on average, the ovary runs out of eggs by age 51. It's the natural, almost universal mean age of menopause in most cultures, ethnics, and racial groups. I mean, it can vary. There's plus or minus, but in any racial or cultural group, it always averages out to age 51. So what controls this very precise decline in oocyte number, and can we delay this oocyte loss and delay menopause? And there's a big evolutionary philosophical issue here between spermatogenesis and oogenesis that I've stated many times. Why should the oocyte begin meiosis? This is a very convoluted thing that God created here. Why should the oocyte begin meiosis and then be locked for a lifetime while sperm are constantly produced by spermatogenic stem cells? Without the mutations caused by spermatogenesis and thus constant germ cell error-prone duplication, there would be no evolution. However, without the locking of the oocyte and avoidance of constant duplication errors, as occurs in the sperm, in the ovary, the species would have no stability. So the ovary stabilizes the species, I guess, and the testis causes the species to be unstable, but to go through evolution. So it all begins here in the epiblast. That's where germ cell specification occurs. And mine was flashing. That's where germ cell specification occurs, and they're not really germ cells yet. They have to migrate up to the dorsal ridge and enter the gonad, whether it's male or female, testes or ovary, before they really become germ cells. There's a gradual differentiation of these so-called stem cells or epiblast cells until they finally are differentiated into PGCs. And if they enter the gonad before they become PGCs, then they'll probably become rests of tumor cells or cancer. And this is just a summary that when transferred into testes or ovary, PGCs give rise to functional sperm or oocytes, but they have to migrate up, and as they're migrating from epiblast and from next to the yolk sac up to the dorsal ridge, they're gradually differentiating into PGCs. Now, the first question to ask is, what is the intrinsic fecundity of individual human oocyte in relation to oocyte age? And the second question to ask is, what controls the decline in oocyte number as the ovary ages? I mean, these are two totally independent phenomenon that the eggs undergo as the ovary gets older. Now, we published earlier this year or later last year the intrinsic fertility of the human oocyte with age, and Pasquale Patrizio mentioned this by 14,000 cycles, natural cycles with single embryo transfer. We were able to figure out, at least without the confounding factors of ovarian stimulation, we were able to figure out what is this intrinsic fertility of the human oocyte. And again, as Pasquale said, it's about 25%. Until you pass the age of 35, about 25% of oocytes are able to result in a baby. And that number goes down relatively rapidly, 10% a year, as you pass age 35. Now, this isn't what you normally think of. You normally think of a much lower pregnancy rate per oocyte because the oocytes we retrieve with IVF are with ovarian hyperstimulation. And if we look at this slide, I'm imposing on our results with natural cycle and with simple Clomid mini IVF protocols, which you see in the original graph and the red lines that accompany it. You can see below that index series published by Lemon and by Patrizio and by Cobo, in which on average there's the live baby rate per egg is not 26%, but is closer to 6 or 7% per oocyte. So normally we think of, at least with controlled ovarian hyperstimulation, we think of the oocyte having much worse potential for making a baby than is natural in real life in terms of the intrinsic fertility of the oocyte without hyperstimulation. So Cobo drew a graph of this because she wanted to know how many eggs you really had to freeze to preserve fertility in order to give a woman, say, a 90% or a 97% chance of having at least one baby. And it was quite a bit. You'd want 30 frozen oocytes to have an 84% chance of having a baby later in life with those frozen eggs. And on the right, you see I make the point that when you freeze ovarian tissue, you get 200,000 oocytes with that ovary tissue. So you get a lot more eggs when you're freezing ovary tissue than when you're just freezing oocytes. And another important study that will help you understand the aging of the ovary and what we're trying to accomplish is this study by Yasui from Japan in 2012, and it was about 24,000 women that were followed for the age of menopause, and you can see that some women go through menopause earlier. The average age is 51, and this graph shows it very, very clearly from premature menopause, age 35, to late menopause at age 60. Now, superimpose upon that women that have had a unilateral oophorectomy, and you can see very, very, very little difference. So removing an ovary in an otherwise healthy woman does not really make her go through menopause more than maybe a year earlier. There's a compensatory decrease in primordial follicle recruitment as there's a decrease in the number of primordial follicles. So the lower the ovarian reserve, in a compensatory fashion, the lower is the rate of recruitment. That's very important for what we're going to be doing with ovary transplantation and to understand the longevity of the human ovary. So now we'll go into some of our work with ovary transplants because it helps us understand this much better. That was the first ovary transplant we published in the New England Journal of Medicine in 2004. So first place to summarize, worldwide, there have been over 148 well-documented, peer-reviewed live births from frozen ovary tissue. So it certainly works. Now, the majority have been case reports, but we have series from Brussels, Israel, Denmark, and our own center that leads us to feel that about 41% to 76% of women with frozen ovaries transplanted later, frozen for cancer, are going to have a successful result with at least one baby. Most are spontaneous pregnancies not requiring IVF, and these were young women who had ovary cortex frozen prior to gonadotoxic treatment. So you got to realize these results wouldn't be quite that good, we're assuming, if these were 40-year-old women that were having their ovary frozen because of, say, breast cancer. So what we observed, that was kind of shocking, was AMH rises to very high levels at the same time that the FSH declines to normal, and it takes about 4 months for that to occur. So we think that it's 4 or 5 months for the primordial follicles to reach the stage where they are making antrofollicles and make AMH and are subject to the ovulatory hormonal cycle. Now, 4 to 8 months after that FSH returns to normal, the AMH declines again, but now to very low levels, indicating severe follicle depletion. Nonetheless, these ovary grafts that have severe follicle depletion remain functional for up to 5 years or longer, despite very low AMH levels. And if you try to do IVF, you might get 1 or 2 eggs at most, but if you just wait for them to have spontaneous conception, as most of these successes were, eventually they'll ovulate a young oocyte and they'll get pregnant. So this is a graph that Helen Skoletsky put together summarizing all of these cases, where the red line shows the FSH coming down to normal levels by about 5 months, and then the AMH in the blue line going way above normal levels for just a little piece of tissue, and then coming down to very, very low levels, but lasting for a very, very long time. So the over-recruitment of primordial follicles after transplant occurs because of decreased cortical tissue pressure. The cortical tissue pressure suppresses primordial follicle recruitment. Cortical tissue pressure is the key regulator of fetal primordial follicle rest, adult primordial follicle recruitment, and thus ovarian longevity. Let's try to support this a bit. Increasing incubator pressure during oocyte culture should arrest oocyte development and form primordial follicles. In contrast, dissolving the fibrous tissue of the ovarian cortex, which decreases tissue pressure, causes FOX3 to go extranuclear from intranuclear, and thus releases the otherwise locked primordial follicles. This has been demonstrated in Kyushu. So primordial follicles were designed to resist oocyte development in order to save the oocyte and stabilize the species. Primordial follicle arrest is the key to saving the oocyte from disappearing after the fertile initiation of meiosis and the continuation all the way through meiosis with subsequent apoptosis. It is also the key to cautious gradual release every month in the young adult of an average of 1,000 oocytes per month or 30 per day. In other words, this mystery of what causes early meiotic arrest in the fetus, well, it shouldn't be mysterious why that's necessary, because otherwise, by the time the female fetus is born, there'd be no eggs left. But it's the same mechanism that parses out gradually the recruitment of locked primordial follicles so that a woman can be having her menstrual cycles and her fertility perhaps as long as till age 51. Now, this is just a picture. It's an animal, but it's the same in all the mammals, where you can see that all the primordial follicles, all the resting follicles, are located in about the outer millimeter, the cortex of the ovary. There is absolutely no development of follicles, no primary or primordial follicles in the cortex. In order to develop, the follicles have to go interior into the softer medulla. Now, in some animals, like the horse, it's a little different because, like the horse is all cortex. The horse's ovary is like one solid rock, and so therefore there's very, very little primordial follicle recruitment. And you try to do IVF on a horse by stimulating them, and you'll get almost nothing. And that's just an example that it's this rigid tissue that seems to hold in check what otherwise would be the automatic development of the follicles, and then they'd all be gone very soon. And this is just another animal just showing again that there are no developing follicles in the cortex. That's all resting follicles, and when they're recruited, they go into the softer medullary tissue. But if you just take a slice of 1 millimeter thick of ovarian cortex when you're trying to freeze ovarian tissue and preserve fertility, you can see that you have all the primordial follicles. You won't lose any of them. This little piece of tissue, which looks like this at surgery, is all there is really to the ovary. The inside of the ovary, of course, is just medulla, and it's just sort of a place to house follicles as they leave the resting pool and begin to develop. Now, this is just a simple graph that we did of the fresh transplants from identical twins, and there's a lot more information to get from these identical twins. It's a rare series that were discordant for ovarian failure. Like we're finding out right now from them what is the age of PGC or PGC specification in the embryo. Is it similar to the mouse? And so there's a lot of data to be gained still from these twin sisters we first reported in 2004. But you can see the FSH is variable, but comes down to normal by about 4.5 months. And then with frozen ovary grafts, we found really the same thing. And in fact, this is just an example of a single patient, and they're all like this, that Helen put together into one graft, where the red line shows the FSH coming down and the AMH going sky high. It's just one little piece of tissue, and then going down to very low levels, and then the graft lasting for 5 to 8 years. So this is just a video. Oh, let's see, we've got to try to get the video to work here. Is it on? Is it? No. Maybe I press this button? I don't know. No. Yeah, okay. I guess that's working. Okay, so this is to show after we thawed the tissue, we quilt it with very small pieces of 9-0 nylon interrupted sutures. And then we put it onto the denuded cortex, onto the medulla of the recipient. I'm kind of trying to look at both. Okay. And then the thing that's most important to us as we finish the transplantation of this graft is that we have a good juxtaposition, a normal position, so that the fallopian tube can pick it up. So here you can see the fallopian tube is in a perfect position to pick up the egg when it's ovulated from the transplanted piece of ovarian tissue. And now this is just sort of a summary, a very busy graph. And if you look on the right-hand side, you can see most of these pieces of tissue are still functioning. And some of them for vitrification, some from slow freeze. I don't think it makes any significant difference. But we have a 77% live baby rate. And sort of to summarize, we had 11 healthy babies from 7 of 9 fresh transplants, and we have 13 healthy babies from 10 of 13 transplants. So with just transplanted ovarian tissue, fresh and frozen, 24 healthy babies. But around the world, as I said, just even with frozen tissue, there's documented 148 babies and probably a lot more than that. So what is the benefit of ovary tissue freeze for cancer patients versus freezing eggs? Well, there's less time to wait before the cancer treatment. There's no problem if chemotherapy has already begun, because chemotherapy will preferentially damage or kill the developing follicles, and the primordial follicles are more resistant. And this is really important for leukemia patients. It's certainly 1/10 or less of the cost. It's less troublesome than going through ovarian stimulation, and return of hormone function can be accepted, as well as fertility of the eggs. Now, this is an example how long this ovary tissue can last. I mean, it lasted for 8 years, the same ovary transplant. This woman had her last baby at age 46, and there she is with her 3 children from just one ovary transplant. So why do these grafts last so long? There's a very low antral follicle count because I told you about the follicle depletion after the transplant. There's a very low AMH, and really only 1/4 to 1/6 of a single ovary, and so why do they last so long? Well, this is what ovary tissue looks like pre-freeze, and I won't show you all the many examples. And this is what it looks like post-freeze. So we didn't really see any evidence of damage from the freeze and the thaw. And this slide from Dror Mayro shows there probably is no damage from ischemia either. I usually haven't done IVF on these women, or if I did, they asked to do it maybe past 8 months or a year later, and we got very, very few eggs. But as you can see, he did it right away after the AMH went up and before the AMH went down, and very, very good follicular response with this IVF protocol. So I'm not sure that ischemic damage is the major cause of depletion of follicles. Something else, and I would postulate that it's the dropping of the pressure. So massive over-recruitment of primordial follicles because of decreased tissue pressure, I think, is the major cause of depletion. And it's not because of an elevated FSH. Subsequent depletion of primordial follicles is not caused by ischemia. Tissue transplants last for many years despite this depletion. And this is another example of, I knew her when she was just 19 years old and had Hodgkin's, and we froze her tissue. And again, I told her I didn't think there was much hope that this would ever work, but there was nothing much else we could do in 1997. And from that one frozen tissue transplant later in life, she's now an oncology nurse. She has 4 babies. And those twins were spontaneous. They weren't IVF babies. So she had 2 babies, one after another as singletons, and then she came up later in life with twins, 4 babies from that one graft. This is a leukemia patient who you saw earlier that we had no idea that we'd be able to help her at 24 years of age, but we froze her tissue anyway. She met the man of her dreams finally when she was 41 years old, and now she has a baby at age 44. And if she didn't have leukemia, most likely she would have been infertile and not able to have any children. But the leukemia prompted her to do this improbable thing of freezing her ovarian tissue. And there she is with her husband and the baby shortly after the birth. And this was another leukemia patient who you see, she's even shorter than I am. That's because she had her bone marrow transplant at a pretty young age. And that's, again, her graph. She had a slower rise in AMH and a slower drop in FSH than usual, but this graft is still working 7 years later. That's her first baby, spontaneous, no IVF. That's her second baby, and that's her third baby. And so we've done this in 3 leukemia patients, and 2 of them have gotten pregnant. We have a total of 4 babies. And the other one has not gotten pregnant, but it seems to be functioning normally, everything seems to be normal, so we're suspecting there may be other problems from uterine radiation. We can do this for many women have total oophorectomies for benign reasons like teratomas. We can just freeze the cortex, and this is true with endometriosis as well, if they just send us the ovary tissue. Healthy women, this is a very, very successful dermatologist who was seeing 40 patients a day at age 35, and she didn't have time to think about going through ovulatory induction, and so she decided to freeze one of her ovaries. So it's not necessarily just for cancer patients. And here's an example of a 35-year-old with breast cancer, and she said, well, she doesn't want to have babies anyway until she's 40, and they won't let her have babies until she's been on tamoxifen for 5 years. And so she said she would have wanted to freeze her ovary tissue anyway at age 35. It can also be used for autoimmune disease. One of the cures for autoimmune disease is bone marrow transplantation or stem cell transplantation. And you totally reboot the immune system. And in fact, I had one patient a male who we froze his sperm just last week, who told me it was interesting because he had a bone marrow transplant for leukemia. We had his sperm frozen. We were going to use that then for IVF. But he had a severe peanut allergy before he had his bone marrow transplant. And he doesn't have a peanut allergy anymore. He can eat all the peanuts that he wants. So it's interesting that for autoimmune disease, you can use a fairly radical treatment like bone marrow transplant, but then you ought to freeze the ovary tissue first. And she was a neurologist that had multiple sclerosis, is completely cured. That's her baby after we transplanted her, in this case, vitrified tissue back. But what if the patient comes to you after she already has had your cancer treatment and she has abundant primordial follicles? That's the issue. She had 6 rounds of chemo before we froze the ovary. She was in menopause, actually, but when we looked at her tissue, she had abundant follicles. So egg freezing is not an option, but ovary tissue freezing was. So she was about to undergo her bone marrow transplant. She had already gone through 6 rounds of chemo. You can see an area of scarring of her cortex, but she still has a lot of primordial follicles that survived, but won't survive when she has her bone marrow transplant. So she was menopausal after the bone marrow transplant, no cancer cells, not surprisingly, but rare healthy primordial follicles that are not being recruited. So she was in menopause, but she still had some non-recruited primordial follicles, which most of the time occurs in early menopause. And that relates to the whole issue of why do these pieces of ovary tissue that have so few follicles in them and have such a depleted ovarian reserve, why do they continue to last for so long? Well, frankly, it goes back to this paper by Biscoff and Anderson. Anderson is in the room right now, but I didn't even know him when I looked up this. I was trying to figure out what was going on. In fact, Bibi, who was working with John McCary, is the one that found this paper for me. It was kind of a neglected paper, but it looked like the only follicles that really survived in the fetal mouse were those that went to the cortex, and everything else was gone by the time of birth. And so that fits with the idea that what controls the recruitment of follicles in adults from the resting phase, and it causes a gradual release from the fibrotic course, and maybe just like the fetus, and it may be an issue of as these eggs migrate to the cortex, to the fibrous tissue of the cortex, that's the mechanism for arresting them and preventing them from being all gone. And actually, if you look at any piece of ovary tissue that we're going to freeze, the stromal density decreases as you go more and more interior. This is the most dense stroma, that's less dense stroma, and that's the least dense stroma, and after that, you get to the medulla. So tissue pressure may very well be a major factor in ovarian longevity. And there may be an over-recruitment of primordial follicles when this tissue pressure is released, and there's a long duration of transplant function despite low AMH, and we have a late menopause and multips. Well, I was just told by Klaus that may not be true, but I'm trying to think of different examples of how tissue pressure may be very, very important in controlling ovulation. So this is a study by McCready et al. In 2017 showing the AMH levels in pregnancy and then after delivery. And the AMH levels went down, particularly in the last half of pregnancy, and then went up after delivery. And the interpretation of Teramoto from Tokyo on this is that normally there is a continual recruitment of primordial follicles, and that's turned off in early pregnancy. And so you notice that in later pregnancy, when you have a decrease in the number of antral follicles and therefore a lowering of AMH. But then after delivery, you have a return to the previous AMH. And interestingly, this increase goes to the pre-pregnancy levels following delivery. And in looking at 8,000 cases, Teramoto came to the conclusion that the AMH is not going down as it should go during those 9 months of pregnancy. And it could be related to increased intra-abdominal pressure. This is the way the AMH normally would decline over time. And this is Teramoto's data showing that there is a decrease in the decline in AMH if you look at pre-pregnancy and then post-pregnancy AMH level in a large population of patients. So what is it that locks and unlocks primordial follicle? It might be tissue pressure. And what about the study of Kawamura, where we've already shown you always will see, at least in the first 3 years of menopause, you will always see some isolated occasional primordial follicles. And these follicles actually look quite good, quite healthy. And they seem to be trapped in this sea of fibrous tissue. And they're quite healthy, but they're not getting out. So the question is it because there is this decreased rate of primordial follicle recruitment that occurs as you have a decreased ovarian reserve, and then at some point, does it just slow down to where you have no recruitment and they're just trapped? So what if we were to bypass the primordial follicle? Well, that's what Katsuhiko Hayashi has been doing in Kyushu, where I'm going in a few days. And I was there, he's the X chromosome, I'm the Y chromosome. And I was there when he was doing his original work, not just with stem cells, but with iPS cells derived from skin cells in mice. And this is that paper. Ori Hikabe was his grad student who was working on this. And this is now a iconic paper, really, from 2016. There is Ori and Katsuhiko in the lab, and I was there when he did the C-section to deliver these very first mouse pups whose mother was actually who was from a mother's eggs, and it wasn't her mother's ovary or her mother's eggs, but it was her mother's skin cells. So it's not that hard to make an oocyte in vitro in the mouse, actually, when you think about it. Now, the primordial follicles are locked by FOX3 being intranuclear, but that doesn't happen when you turn skin cells into iPS cells into epiblast cells, epiblast-like cells into PGC cells, and then you culture an FSH for 11 days. And by the way, there's no FSH in the culture media that Hayashi is using for developing PGCs from the iPS cells and the epiblast cells. So I don't understand the FSH right now. But he does use FSH once he has the aggregate from PGC-like cells to produce oocytes, FSH for maturation for about 11 days, then HCG plus FSH, and then we have M2 oocytes. So this is an example, his graph that he drew, of in vivo development versus in vitro. And in vivo, you have these primary follicles, primordial follicles, that are locked and only develop slowly and release gradually over the woman's lifetime. But with in vitro, you can see that you're skipping that stage. And that's a way in a problem, because as soon as you have these PGCs developing into oocytes, they immediately become secondary follicles, M2 oocytes, and you lose them. It's not beautifully designed like in vivo, where you lose them gradually, 1,000 a month, but they're gone immediately. So now what Hayashi is trying to do is use this idea of pressure to actually go right to what we heard earlier coming from Northwestern was, let's make an ovary, because an ovary would be, let's make an artificial ovary. That would probably be better than just trying to use these oocytes made in vitro. So what he found was nuclear localization of the FOX3 gene was what caused the primordial follicle and what locked it in development. And if he were to take away the fibronectin and take away the fibrous tissue, the FOX3 would go from intranuclear to extranuclear so that you could get development from those primordial follicles. Furthermore, let me just see, yeah. Furthermore, when you remove the extracellular matrix, you're able to, what's happening is that the FOX3 goes extra and they develop. But what about increasing the pressure in the incubator? I guess I don't have, if you increase the pressure in the incubator, again, you get a slowing down of oocyte development. And so the summary of the aged ovary is that there's a sudden loss of tissue pressure after transplant. And this loss of tissue pressure with a high fibrous tissue to follicle ratio then reduces the rate of primordial follicle recruitment. The ovarian cortex participates in the locking and unlocking of the primordial follicle, and this underlying mechanism is disrupted by the transplant. Intrinsic tissue pressure is a common, I'm sure it's not the only one, a common mechanism at work to control primordial follicle development and extinction. And I like to make this point that it's so convoluted that we would have spermatogenesis making hundreds of millions of sperm per day in the male, and a 90-year-old man can be fertile, and yet the woman's eggs are not developing. She goes through meiosis extremely early as a fetus, and then is stabilized and locked in meiosis and becomes less and less fertile as she gets older. So I think I'll skip that, yeah. So I made the point, so I wanted to skip through those very quickly. So this convoluted mechanism, and then we'll go for questions. This convoluted mechanism, I think, is and actually it was Hayashi's original theory, is a beautiful way to allow evolution to occur, but that be balanced by stabilizing the species. So the ovary stabilizes the species, but the testes allows the species to either go awry or to evolve in a different way. So thank you very much.